welcome to everyone to this question and answer session with the Health and Social Care Minister, Lawrie Hooper. The government conference last year came up with some feedback, which was that people would very much have liked some evening sessions because lots of people work in the day. So hence we've put these Q&As on tonight, and they've been really well attended. So thank you for people choosing to spend your evening here with us. These are sort of standalone. They're separate to any of the other presentations. They are no frills as billed, no pre-prepared questions, no spin. We don't know what you're going to ask, and he will try and answer your questions and do it as fulsomely and honestly as the time allows. There are two ways that you can ask your question. You can stand up and speak your question. We have two people with roving microphones. Or you can use Slido, so you can capture that QR code on the screen behind me, which will allow you to pose your question via your mobile device, and by magic it will turn up on my tablet. All you need to do is choose Cinema Room when you get in. If you can't get in via that, go to slido.com and it's hashtag IOMGov23 and get in that way. But as I say, you can stand up and speak your question, or you can send it through and I'll read it out for you. So because we're running late, I've done a bit of a warm-up with the last two ministers. I think we perhaps ought to jump straight into the questions. I will warm you up by just asking, are you looking forward to this?
I thought I wasn't allowed to spin it. Yes, of course, absolutely.
I mean, raw political engagement, politicians go round and knock on doors, so presumably this is the sort of thing they like. So let's have some questions from the floor. I can see a hand up there, 3 rows down.
Thank you. Yes, thank you. Alison Gom. I just want to ask a question about the establishment of Manx Care and the relationship between Manx Care and the Department of Health and Social Care. Set up on one of the recommendations of the Jonathan Michael report, and to me it looked very much like a situation we used to call in the UK under Westminster with agency status for some government bodies, of which I was familiar. And so for me it was that the patient-facing staff are dealing with all the operations, leaving the policy strategy to the Minister in the Department of Health and Social Care. And it's just struck me in the last few months that that relationship isn't quite working like that. A couple of examples. The announcement about the closure of Cummal Moor in Ramsey, and also at a recent meeting that was broadcast, I think, through Manx Radio, that there is a possibility that dental charges, there may be some people will be exempt from having free or access to dentists according to a means testing, and that struck me as really a significant change of policy, because that's surely one of the tenets of the establishment of a National Health Service. It seemed to me as well you were a bit wrong-footed, caught off guard by a couple of those announcements, so it was a bit of a surprise to me that perhaps there was not much talking about these ideas before they appeared in the public. And I just wonder if you feel this is the way you thought this relationship would go, and how it's working.
So I think part of the problem that we have actually is the way that our media report things. So the dental comment you make reference to, if you listen to the conversation happening around the board table, you can actually access the whole board meeting. It's all there. Manx Care Board were talking about some of the challenges they were facing around funding and around resourcing, and the comment around eligibility was one of the operational directors of Manx Care saying, look, if we don't get this sorted, we are going to have to start talking about some of these other things. So it wasn't a recommendation from Manx Care, it wasn't Manx Care saying this is what we should or even will do, it was literally a comment, someone saying, look, there are real problems and these are all the potential consequences if we don't deal with it properly. The radio, on the other hand, reported it as if it was something being actively considered by Manx Care. Now, things like charging regimes, for example, have to go through Tynwald. So that would have to be the department taking something to Tynwald for approval, so it wouldn't originate inside the Manx Care boardroom, almost. So there is definitely a lack of understanding out there, I think, about the relationship and the different roles of the department and Manx Care, and I think some of that misunderstanding exists within the media as well as out in the public, and then when these things get said, things get blown a little bit out of proportion, I think, and that isn't helpful. If I'm perfectly honest, it really would be better if people, especially our colleagues in the media, were able to report accurately. It's not the first time this has happened. There have been other stories that have been run by the media. There was one around the development of a vaccine injury service that I found out about on the front page of the newspaper, which, it's always great when you find out things like that. It's not something that's actually happening, but again, it was a conversation that somebody was having, and it's been misinterpreted by, in that case, it would have been the newspapers, I think. So, yes, it is probably not exactly, I think, as was envisaged, but I think the reality is the Isle of Man is always going to have these kind of overlaps in the grey area, and when we, in the department, try and develop policy, we should be doing it in partnership with Manx Care, because that's where all the clinicians work, and you don't really want to be developing and imposing things on people without their input. So it has to be more of a partnership arrangement than you get in, say, the UK, where Sir Jonathan was kind of basing his recommendations on this commissioner relationship. I think we need to be a bit more informal, and there is a little bit more overlap, and I think that makes it complicated then when you're trying to explain things to the public, because actually it isn't black and white. A good example is, where does strategy and policy end and operation begin? Common Law is a really good example of that. Manx Care is in a situation looking at making changes to the way they deliver social care services, actually in line with the department's Home First policy. At what point does the department say, actually, we think you should run X number of care homes, you should run Y number of facilities, or do we leave those kind of decisions up to Manx Care? And that's the kind of evolving process we're going through at the moment, I think. If you look at the mandate that we issue, we don't prescribe service levels at the moment. We should, and we will be doing that as we go through, but at the moment we don't do that, partly because the department doesn't have the resource to go through every single service and specify exactly what we think should be delivered, and partly because personally, I don't think it would be helpful to go to the nth degree. Manx Care have to have some level of operational flexibility to be able to deliver care without needing to run back to the department every 5 minutes if they need to make minor changes to services. Now, big changes I would accept need to be consulted on and engaged with properly. But it's a very new structure, it's a very new model, and being completely honest, when Manx Care was established, a lot of thought went into setting up Manx Care. There was a shadow board, things were running for a period of time, but even that missed a lot of things. There's a lot of stuff that we're finding out now, that Manx Care are finding out now, that no one really knew about 2 years ago when it was set up. But even with that, not a lot of thought went into the department. So the department is basically brand new. Most of the staff, most of the executive are all new members of staff in the department. They weren't there 2.5 years ago. We didn't have a well-formed policy team that we inherited. We didn't have a strategy team. We didn't have a commissioning team. It really was very much a bare bones kind of model, and it's taken a couple of years really to start building some of that capacity so we can do the things that Sir Jonathan's report really envisaged that we would be doing from day one almost. So it hasn't been an easy ride, if I'm honest, there, and it hasn't been without bumps, and I don't think it will be without bumps, if I'm completely frank, especially as we go through the process now of changing the way we regulate care, changing the way we provide oversight, especially with some of the requirements that are placed on us by Treasury in terms of financial oversight. It's going to get harder before it gets easier, I think.
So in terms of the overall structure of the relationship, and as you say, Manx Care only came into being in, I think it was April 2021, where the DHSC is much smaller, it doesn't run things anymore, it's responsible for strategy and policy, and Manx Care, our own NHS, is the delivery body. You've talked about, how sometimes there is some overlap. Do you still support that basic structure as a very sound way to go about it?
Yes, I think in short, and the reason for that is we are seeing quite significant improvements in care, in quality and safety that weren't happening under the old DHSC model, and I firmly believe would never have happened under the old DHSC model. And so we are starting to see improvements. A lot of it is governance, a lot of it is behind the scenes, a lot of it is clinical safety, but it's stuff that should have happened 20 years ago in some cases. And so yes, I think it is adding a lot of value the phrase that is often used is we've professionalised the service, and essentially you're letting people that know what they do run the service. The challenge then, of course, is the political interface, the interface with Tynwald and the public is kind of our job, and that gets a bit more complicated. But yes, in short, I think it is working because we are definitely seeing improvements. The challenge, obviously, we have at the moment, predominantly as a result, I think, of funding issues, is it's very difficult then to translate some of these sort of back office, behind the scenes benefits into things the public can actually start seeing and gripping. Shorter waiting lists, shorter waiting times, but generally I think we are seeing better outcomes from the service, which has got to be a win for everybody.
Okay, thank you. I've got a question that's come in on Slido. I don't have a name for this one, but it's very much a talking point around the island at the moment. I'm in support of Dr. Allinson's assisted dying bill. Would you agree it's time the Isle of Man looks at this again? And if so, are you in support of the bill? So you're speaking here as an individual, not as the minister, or are you?
Good question. So whether I think it's the right time or not is irrelevant, because there is a private member's bill coming through the House of Keys. We are going to be talking about it. There is nothing I can do to stop that short of pushing Dr. Allinson under a bus. The reality is we are going to be talking about this in the next couple of weeks. As the health minister, I've decided deliberately the health department has not taken a position on this, because actually there are so many staff involved and so many complexities. The only involvement the health department has had in this piece of work is to feedback operational concerns to Dr. Allinson in terms of how his bill would affect the service if it becomes law, because if it becomes law, whatever we think we have to do it, that's the law. So we will have to operationalise it with Manx Care and make sure it works. So that's the involvement that the system has had in the bill. From me as a personal perspective, I am quite supportive of what Alex is trying to do. I actually don't think his bill quite goes far enough in some areas, and I will be bringing some amendments myself in my own name as a backbencher, almost, as an individual member, not as health minister. So again, whether those go through, whether they're supported, will be up to the House ultimately. But yes, broadly speaking, I am personally very supportive of what's being proposed. But as a health system, my overriding concern is making sure that if the House of Keys chooses to pass this as law, that it will work in practice and that we can make sure we can deliver then what is expected of us by Tynwald.
Shall we just stay on that subject? Because I'm sure lots of you have views. Does anybody else like to contribute rather than zigzagging somewhere else and coming back to it? Happy to take some more questions on it now, or views? No. In terms of operationalising it, can you give us any idea of what that would look like, or is that not something anyone's got?
I probably can't, to be honest. No. So ultimately it will depend on what the final bill looks like, because that will determine process, procedure, eligibility, which will impact then on how you deliver it. I think from the feedback we've provided so far, it's been very much around getting clarity on some of the terminology in the bill and clarity on what the expectation is, especially around things like conscience opt-out clauses and other things. But the bill itself is about 12 pages. It is pretty small, so it should be relatively straightforward. The challenge we're going to have as a department is if the bill is passed, there will be regulations needed. Quite a lot of regulations, as is in the case with any bill, and it will be on us then to deliver those. And that's when I think we will have to get much more involved in the detail. But yes, at the moment, we're not committing too much resource to it, because there is every possibility the bill doesn't become law. The House of Keys says thanks, but no thanks.
I'll take another question from the floor. This gentleman here, please.
I've actually got another question. I'll just do two quick ones, if that's okay. First one is, in 163 days, Canada will be including the mentally ill as inclusive of the assisted dying bill. Do you think that there is any way to stop that from happening here at some future point? Because they have Bill C7, which is altering their existing primary legislation.
The short answer is no. Tynwald can legislate. It has exclusive competence, so Tynwald could make it legal to do pretty much anything they want it to do. So there is no way of stopping that. Parliament is sovereign, and if Parliament decides to legislate, they legislate, and the law changes. So no, I don't think there's any way you can prevent the law being changed. We've seen that in the UK with some of the things that the Conservative government are doing that I think 5 or 10 years ago you'd have thought they would never have touched. But actually, yeah, Parliament can do what it likes almost.
Second question, the usual threshold for the vaccine injury that you mentioned earlier is 1 in 100,000 would normally stop a vaccine rollout. With the COVID vaccines, The current number of people that have reported to the yellow card system from the vaccine injury group is 1,061, and that's just the ones that have publicly made their views known that they've done it, which would indicate an adverse event rate of 1 in 79 instead of 1 in 100,000 that would customarily stop the rollout. What's your view on the booster campaign now? Do you think that it should continue, or do you think there should be a pause while we look at it?
So we follow JCVI guidance in the UK. Their position is the vaccine is safe and should be rolled out to the age groups that are being recommended. We're very much following that clinical guidance. I'm not a doctor myself. I can't comment on the incident rates. I know the yellow card scheme is self-reporting, so if I did throw Dr. Allenson under a bus, he would be very happy to report that to the yellow card scheme and say that was because one of us had been vaccinated. I'm not sure how reliable an indicator that is for such a small population like the Isle of Man, which is why we don't have our own vaccine injury reporting scheme, because the numbers would be too small to make it of any statistical value. So I can't comment on the clinical aspects. All I can say is JCVI are clinicians. They are the people that make these recommendations for the United Kingdom. We have chosen as a government to follow JCVI recommendations as opposed to, say, the American CDC or the EU CDC. I don't see any reason to change that approach, not unless some significant information comes to light. But at the moment, following JCVI as we have done for the last few years seems to make a lot of sense. I think we follow them for all of our vaccine programs, if I'm perfectly honest. And again, it doesn't seem sensible to deviate from that unless we've got a really good reason to do so.
Okay, thank you. I've got a question come in on Slido now from Georgie Shelley from the Manx Eating Disorders Support Group. Is there any scope for future health services to support people with eating disorders as a dedicated service? The charity Manx Eating Disorder Support helps people at all stages, but we've seen a large increase in referrals to our service.
That's quite an interesting question. At the moment, I'm going to say no. And the reason for that is quite straightforward. Manx Care are forecasting an overspend of around £30 million, 27 point something, I think, before Teresa throws a book at me. But the reality is there is no money for new services. I've been very clear with Tynwald, there is no money for service enhancements. There is no money for additional services. The money that we have has to be focused on transforming the services we do have so they can be delivered as efficiently as possible. It is not a very good message to be sending to the Manx public. It's not a particularly happy place that I'm sat in, but I'm going to be honest with people. I'm not going to promise them things that I know full well the service can't deliver. And so whilst it's looking at specific issues like, for example, eating disorders, it could be very valuable. It could be something that is worth doing in future. But right now, we're trying to keep the lights on, and that's what I'm focused on.
Though there can be services where you can actually do a lot of good and help people with relatively small sort of cost or footprint. Maybe this is one such.
Yeah, that's true. And as part of the transformation programme, there is a work stream which is broadly called Care Pathways. And the whole point of that is to go through all of the care pathways that are on offer and see if they can be brought up to date, modernised, improved, made better. Some of those, the cost will be not very substantial. But the reality is when we are going to be £27 million over budget, even a service that costs £100,000 is still something we can't afford. And that's the horrible truth, really, of 10 years of underfunding a health service. This is where you end up. They're very live conversations we're having, and we're going to have with Tynwald colleagues, with the public, about what the health service looks like, the shape of the service, what services we expect, the level of services that we expect to be delivered. They're not going to be easy conversations to have, but they're conversations I think we have to have, and conversations that are really overdue.
So if Georgie's in the room, presumably is, because the question was tabled, that's a very honest answer, and there may be ways perhaps your service could perhaps be assisted with some other form of support from the department or from
that's
care,
fair.
in terms of support as in people, not paid people, but advice and maybe a room or something like that.
So one of the success stories over the last few years has been the development of the ME long COVID service. And part of the reason that was so successful in its rollout, I think, is because there was a lot of close working with the third sector, with the charity that was heavily involved with that. And as a system, I think we do need to do better engaging with the third sector and trying to make sure we're all aligned. And one of the things that I've seen over the last few years in politics is charities coming forward with great ideas, things that are really valuable, but they're not really things the health service would say they need. And if you came and asked the health service, I've got £1 million, what would you like me to spend it on? you get a very different outcome to just a charity saying, I would like to buy you this piece of equipment or this new facility or whatever it may be. And so there's definitely a piece of work that needs to be done that we are looking at in the department as to how we engage better with the third sector. They have something in Scotland which they call the Healthcare Alliance, which is essentially a group of third sector charities that they utilise and they commission via that process, which seems to have a lot of benefits to it. Brings the third sector together, makes sure they're more integrated in how they deliver care in Scotland. It's something to look at here, definitely. But again, a lot of it will come down to resource and priorities, and really the same message stands that it's very difficult to develop new services, to enhance services, to improve the way we do things when you really are under the cosh financially.
Okay, can I have another question from the floor? This gentleman hasn't asked one yet. In the aisle here. Here comes the mic.
Oh, thank you. Earlier on this year, I fell over and ended up in hospital on a Friday evening. Not much happened in the weekend except an x-ray. I got discharged on the Tuesday with a request to go and see my doctor in 10 days or a fortnight. So I left it a fortnight, went, and when I got there, he said, what can I do for you? I said, well, I've been told to come. He knew nothing about what had happened. And also then, about nearly 3 weeks later, I got a letter that had been dictated on the day I was discharged from hospital, but it had taken nearly 5 weeks to arrive at my house. I think there's lack of communication between one person and another person. Thank you very much.
So without looking at an individual case, it's all about joined upness, isn't it?
Yeah, and I think the reality there is that does happen. People do fall between the cracks of the system as it stands. Yeah. But I think that is, it's not uncommon for letters to take time to be sent. It's daft that they're still communicating by letter. In some cases, there is a big conversation. There is a big conversation with the Information Commissioner's Office around how things can be done digitally, because they have had some concerns about email being used, for example, which is, from my perspective, insane. But I'm not the Information Commissioner. So there are definitely things that can be done better. There are systems improvements. Again, the Manx Care Record gets talked about a lot. And if we could have a single integrated care record on the island, that would never have happened, because their doctors all have access to the same systems and all they have to do is click a button and see what was going on. Again, that requires investment. It requires time. In a perfect world, we'd have that already. But yeah, there's a lot of work going on with Manx Care as well around how we make sure people don't fall between those cracks. So looking at discharge pathways, for example. So in your case, when you were discharged from hospital, that follow-up should have been much quicker than 5 weeks. Equally, there are things people can do themselves. So the MCAL service at Nobles are pretty good, actually, at answering queries, and they do have access to the information. So if that had happened, what you should be able to do now is pick up the phone to MCALs and say, can you just find out what's gone on, please, because my GP doesn't seem to know anything. They should then be able to find out what's happened, what the consultants are doing, and get you the information, or get the GP the information. So there are kind of stopgap measures in place designed to try and help, but ultimately I think some of it will require investment in systems and processes and improving the way we do things.
Not to waste time, not what the doctor's appointment. This time it was the reverse, the total going different.
Thank you for that. I'm going to go over here to Margaret Brown, isn't it? You asked a question of the Chief Minister, which he answered as far as he could, but there was, if this is what you're going to ask, about services for a bigger population, which he said you might like to put to you.
It was also, just going back to DHSC and Manx Care, when that was suggested, my hope was that there'd be less top-heavy management, because you could tell me I'm wrong, but generally speaking, I think people feel that there's top-heavy management and huge middle management, and the people on the coalface, if I'm allowed to use that word in our green society, there are not enough. And if we had less of the management side, also perhaps more funding could go into waiting lists. I mean, there's nearly I know a lot has, but there's still nearly 10,000 people across all waiting lists. There's 3,000 waiting for dentists. Lots of those are children. And I just heard on the radio the other day, you've got a finance officer at Manx Care and you've got a finance officer, or whatever the title is, at DHSC. So it just seems that rather than having less management, it would appear, unless you can sort of say otherwise, that there are more. And it's just really, is that a way of, if you can have less management, even if it's by retirement and not replacing, to free up some funding for both the people that are doing the caring and also the waiting lists that are huge.
So you'll be pleased to know that our finance officers are provided by the Treasury, free of charge. At the moment, do not get any ideas, Paula. So the Treasury provide finance support staff for all government through the shared service, financial advisory and financial shared services. So it's a centralised government service for us in the department and for the support that's provided to Manx Care. I think the total cost of the Manx Care structure is around about £3 million a year, I think. The funding gap that we have this year is nearly £30 million a year. So even if it was desirable to close that down, actually you're not touching the sides in terms of what needs to happen in terms of improving patient outcomes. But the value of that £3 million, I think, is being seen readily, daily, through, I touched on it earlier, around things like safety improvements. So the most obvious one of those that I think is public knowledge will be around the operating theatres. They've been accredited now, that's never happened before. That means you go into an operating theatre at Nobles, you're going to come out in one piece. 10 years ago, I don't think a health minister could have said that confidently. And that's the value of professionalising the structure. That's the value of investing in governance, which some people will see as a top-heavy management structure. Ultimately, though, back to the underlying question I think you're really getting at, what happens when the population grows? And I think the reality there is, if you get your structures right, the system you have could cope with a small NHS trust-sized population. So the smallest NHS trusts in the UK are around 250,000 people. If you get your structures right, then actually the service you've got that supports 80,000 people could also support 100, 120, 150,000 people without needing to balloon your management structure again on top of it. So the reality is, I think, if the population grows, and the population will grow because we are seeing inward migration, it's inevitable whether we want it to or not. I think it's going to grow mostly. That's working age people. Working age people tend not to need to use the health service too much. In theory, at least, they contribute more than they take out. The system balances itself out. But because you have a system that can cope with 100,000 people without needing to employ more, ultimately the system does prove beneficial. And it comes to, even at an operational level, it's the same principle. So you need a certain number of nurses to run a ward. That ward can be empty or it can be full. You still need the same number of nurses to run that ward. And so ultimately there's a lot of fixed cost built into modern healthcare that you just can't avoid. So yeah, it feels expensive for a population of 83,000, but when you look at it and think actually the same system could cope with a population of 100,000 without any significant increase in cost as a result, it does start to make some sense. It is just the nature of being a small island, I think. Where we can, though, we do try and partner with UK-based organisations, so there's a lot of work with tertiary care providers in Liverpool, for example, Alderhay, Clatterbridge, and the logic behind that is we can't do everything ourselves, so some of it we do rely on those partnership arrangements and partnership working to try and not outsource as such, but try and make sure that where we can, we aren't employing people here just for the sake of it. Actually, if we can rely on clinical governance oversight from Liverpool for things like the nuclear medicine service, for example, why wouldn't we do that? So the service does try its very best to minimise that kind of growth in headcount, that growth in management and oversight. But it is necessary. It is unfortunately the case that we've gone through a long period on the Isle of Man where we've kind of made do, and professionals as a result are at risk of that because they're not able to comply with professional obligations. The system itself wouldn't be considered safe, and you'll have seen that if you've read any of the CQC reports that have come out. There are big areas of the health service where, from a UK perspective, they look at it and say, actually, I can't hand on heart say everything that is going on is 100% safe. And that's what we're working towards, is to try and make sure that it is, in every case, going to be compliant with those standards. And ultimately, again, like I've said a few times, that comes with a cost. And some of that cost is in through increased management, increased oversight, increased governance. And you just have to almost trust in the fact that that does produce better outcomes for patients. And that's where the department's job then comes in, is to make sure that when Manx Care is delivering, that those patient outcomes are improving.
Do we have time for one more, or do we need to close? I did get a message. I think we may be in danger of being locked inside the the Villa Marina if we carry on. I'm going to have to leave it there, but for this audience...
Say something. This is a scam. I've got a question here. It's linked to this gentleman. Is it acceptable, I would say to you, is it acceptable for a patient with cancer, gastroenterology appointment, to wait 10 months after it's been cancelled, to wait 10 months for the next appointment? That appointment was then cancelled again, and the next appointment is for 2025. That's a total. This patient's been waiting 28 months in total, and she hasn't seen. And in 28 months' time, there's no guarantee she'll see it.
I'll allow this question on waiting list, because I think we all expected there would be questions on waiting list. If you could give us a really quick answer, Minister.
I have a quick answer on that. And also, is it, another part of the question is, when an appointment is cancelled, it looks to me very much like that person who's had that cancer appointment goes to the back of the list. Yeah. The back of the list. That's just to the back of the list. So we're talking here about somebody with a serious thing to wait 28 months, and she hasn't seen anybody yet. She's more likely to see an undertaker than a professional.
So the waiting lists would be managed by the clinicians, so they will be done on the basis of clinical needs. So the only reason you would go to the bottom of the list.
But that's sort of carry on, and that's only one in one family. I've had appointments cancelled as well, and I'm still waiting for one. But you forget about that. The big one that says something like 28 months. And you can sit there and you can tell me, Manx Care is working. It's not working, it's a shambles. And I think everybody in this room would agree to me. 28 months, is it acceptable? No.
So
Tell me it is acceptable.
I'm not going to tell you it's acceptable. I'm going to tell you...
It's not acceptable, and tell me what you can do about it.
I'm going to tell you that you get the health service that you pay for. So Sir Jonathan Michael's independent report turns around and says that if to have a well-functioning, well-run health service, the budget... Let me finish. The budget for that should be £370 million. We are currently giving them 312. So...
Let's hear the answer.
If you don't want to hear the answer, then that's fine. But again,
No, he's trying to tell you.
Acceptable
What?
or not?
right. If you want to have 18-week referral times, if you want to have waiting lists that are not 2.5 years, we need to pay more into the system. It's that simple.
The system is not working.
No, we have a system that is delivering for what we're paying for it.
Hey, 28 months to wait for an appointment. And that appointment may be cancelled, and that person will go to the back of the list.
So here's the question for you then. Would you be willing to pay more into the system to have shorter waiting times?
Well,
That's the question.
yes, probably would.
Okay. Well, that's what we'll do. That's been my position since I was elected in 2016, that the system is not being funded.
Is Manx Care working? There's nobody in this room, I don't think, that agrees.
Sorry, when was the last time on the Isle of Man gastroenterology had a shorter than 3-year waiting list?
Have you got any doctors in the hospital? Have you got any professional people? It seems to me like you haven't got anybody to deal with opticians, eye problems. You've got nobody to deal with gastroenterology. How many people are actually working there?
So there are about 3,000 staff working in the health service, and they are overwhelmingly nurses, doctors, clinicians.
There's more chiefs than Indians.
No, there aren't. And I'm sorry, but the reality of the situation is, if you pay into a system that can provide...
A system now that's not working.
Yes.
You get that through your head. It is not working.
And the minister's saying that to make it work in the way you would like it to work,
You need to pay more.
you need to pay more.
She's talking about, we're talking about here and now.
Yes.
Yeah.
Yes.
That length of time.
Yes. Absolutely. If you pay for a second-class postage, you get a second-class service.
We are getting second class.
But that's what I'm not happy with. That is my point. Since I was elected in 2016, I have been exceptionally clear. My position and the position of my party has been that the health service is underfunded, and we need to invest in our health service if we want to see better outcomes. That is what we are trying to do as a government. Yes.
Yeah, they are. Great.
Yeah.
If you accept as a health minister, you'll accept patients dying before they see a specialist.
I would rather not accept that. I would rather be able to go back to the Manx public and ask the question, as I have done with you, would you be willing to pay more to get better outcomes? I would be happy to pay more to get better outcomes.
I would too.
You're in charge now.
That's not the question.
You're responsible for what's going on now.
I am, and that's what I've tried to explain.
How many people in this room are happy with things, care?
About future
Have you had anything to do with
Sorry, no, I'm not talking about future funding. I'm talking about immediate funding. That's what I'm talking about. I'm talking about this year's financial gap. I'm talking about the money we need today, not 10 years from now, today. Money that, according to Sir Jonathan's independent report, we should really have been having under the last administration. That was a decision that was not taken by the last government. So we are, at the moment, picking up the pieces of, in my view, and this is a personal view, not the expression of the government, 15 years of underfunding.
How do we reverse it?
I'm getting signals that this venue is now not going to be available to us for an awful lot longer. Thank you for that. You've raised a huge issue, which is the funding of the health service and what can be afforded. The Minister will be around all day tomorrow. I'm sure you can find a way to bump into him and continue that